we're going to have Dr. Ximin Li present his paper, and after that presentation, we will have their slides here, and we will just get their voice through Skype and make it easier. Okay? So I'd like to introduce Dr. Ximin Li, who's professor and chair at the Department of Psychiatry at the University of Alberta, and works on a number of things clinically and in terms of basic science interests. And one of his long-standing interests is in white matter changes, neuroprotective and neurodegenerative effects in a variety of disorders. And he's going to talk about white matter as a new therapeutic target for depression. Thank you, Dr. Li.
Great. Good afternoon. Welcome to this session. I would like to thank my colleague coming with me from Canada, and also the host. Great place, great weather. So today I want to spend a little bit of time talking about our work in recent years, focus on white matter. And first few minutes, I want to focus on the current status of depression treatment. And I know there's quite a number of clinicians in the department, in the audience, but I want to quickly go through this. So try to understand the depression and some more quick facts about depression from clinical point of view. And so there are some core symptoms. Actually, there's only two probably we can concentrate. Is a depressed mood, anhedonia. That means loss of interest. And in Canada right now, we really emphasize the mental health in all our healthcare system. And there's a high prevalence and also in heavy financial burden in our society. Certainly, we pay a lot of attention about suicide, high mortality rate associated with those depressive disorder and other related mood disorder. So what is depression for the common kind of language? Actually is behavior parameters, impaired work ability, poor social function, and psychomotor retardation. And sometimes thinking better of dead, thinking of suicide, and believe of bodily illness as well. So what's the psychiatry explanation to the patient and to the family and to the public? So the depressive illness is clinically different from the blue, involve chemical changes in the brain. So we normally tell the patient you have an imbalance of your brain chemicals. But in the treatment, we also have two sentences we really use very much. It's kind of pills for symptoms, talking for problems. So the treatment for depression is really two major approach, talking and pills. And in this society, actually in our professional approach, most time we focus on pills. So what's the neurobiology of depression? Old story, last 100 years and progress very slowly, sometimes dramatically. So the hypothesis still the mainstay of the approach. Depression is caused underactivity of monoamines in the brain. That's the hypothesis, but there's some limited evidence. Mostly publish the supportive information, and sometimes it's very limited. Depression really involved with the three neurochemical transmitters, but recently there's other indication for other neurotransmitters and neurochemicals. There's a delay in the treatment, so there's a post-challenge of traditional therapy, and we need to have a better story to our patient and a better guidance principle for the drug development and therapeutic strategies. So this last 20 years, there's so-called that time new hypothesis, neuroplasticity and neuroprotection. That's another part thinking neural system or neuronal system at that time is the dynamic plastic system. And then stress is a major factor, interact with the genetic and other hormonal, medical, biological factors, and make depression appear in some population or not appear in some population. The therapy for the depression, first We all therapists, including family members, our boss, and a colleague for some issues. But when it comes to depression, there's schools of psychotherapy really have some kind of practical or scientific evidence that are effective. And also, the recent years, a lot of progress in physical therapy or stimulation or neuromodulation or neurostimulation therapy. Actually, that's not new at all. The ECT started 100 years ago and still very prominent and effective. And according to the ECT story and approach, so there's more stimulation, especially RTMS, vagus nerve stimulation, and deep brain stimulation. Those really come up very quickly in the last few years. So the ECT, everybody know, electroconvulsion therapy for the treatment of treatment-resistant depression, especially people with psychosis or suicide tendencies. RTMS is non-invasive method. At least we know it's a non-invasive. We don't know a long-term effect. And use magnetic and induce electromagnetic current in the brain regions. And sometimes we emphasize focused stimulation. Sometimes we focus kind of broader stimulations. Deep brain stimulation comes from neurosurgery colleague, and it's not widespread, but certainly very expensive electrodes, and it's an area further study needed. Vagus nerve stimulation is in theory, some cases successful. It's not wide used, especially we have other methodology. So I come back to our main interest is drug therapy. So drug therapy is very effective, as we know, but at the same time, as good as we can get. So the effective is around 60%, and the placebo is around 40%. That's as good as we can get as a psychiatrist. Because the medical therapy and physical therapy not enough, so we're looking into other called complementary alternative therapy with Chinese herb, Tai Chi, and I'm sure in Turkish culture there's other issues such as Turkish coffee and Turkish baths. And then in China right now, a lot of square dancing and mahjong. So come to that's the overall what we have for the treatment of depression. Certainly there's a ketamine come up with a new theory and new effect. So our colleague Dr. Serdar Dursun will discuss that in his talk. So come back to the traditional data. Right now I focus on the work in my lab in last probably 10 years. That time we study neuroprotective effect of antidepressant, both in cell culture and in animal models. This is the animal model showing chronic venlafaxine, also called effector, facilitate recovery of BDNF, BCL2 marker in the rat model. And that time when we emphasize what's beyond gray matter and what's beyond the neurochemical neurotransmitters. So we focus on the hypoconnected brain. That means the wearing the optic cable in the computer or motherboard. So we believe white matter really matter, and white matter involve a lot of mechanism, emotion, and exact functions. So white matter abnormalities are highlighted with increased severity of depression and with the neuroimaging model. So the white matter compose oligodendrocyte and also have a process and myelination. So here's oligodendrocyte from all those, and the shielding of neurotransmissions. So the major psychiatric disorder with white matter damage, actually we see a lot in the neurological situations such as MS and other illness. And with the schizophrenia and depression, certainly there's evidence showing white matter deficiencies. And we'll try to focus on different kind of area of the brain, and with the neuroimaging study showing the white matter deficiency both in schizophrenia and depression. What about the treatment effect on those white matter in the different model and also reflecting the biomarker of neuroimaging? So the fluoxetine, Prozac, and imipramine tricyclic reverse the loss of neural stem cells in the subventricular zone of mouse model. That's the typical model of a chronic stress. There's antidepressant. This model also responsive to ECT treatment, and also environment enrichment stimulates proliferation of those progenitor cells. So with those in mind, we develop another model and try to study the further mechanism. So here is the early study by another group showing the oligodendrocyte dysfunction in depression. This is a postmortem study. So the general approach from my lab and others is myelin and oligodendrocyte dysfunction is etiology factor in the development of depression. And then stress is still the major factor and makes things worse or better. And therapeutic intervention have a benefit effect on subjects suffer from depression, and not only emphasize on neurotransmitter, but let's emphasize the white matter. So we use animal model traditionally unpredictable chronic mild stress model, and just make the mice uncomfortable, stressful, just like jet lag. And then we look at the effect of this venlafaxine, attenuate oligodendrocyte, so also other protein markers. So we see the really promote oligodendrocyte. Another animal model we use is neurotoxin cupzone. This is neurotoxin to induce MS model for years, but we use a much lower dose. So in this way, there's a limited neural degeneration or demyelination, and not produce any sensory or motor deficit, only produce the cognitive deficit and behavior impairment. And this give us a lot very clear window of treatment and recovery. So here is the result with the macro MRI showing quite typing and really prevent mice from cupzone-induced demyelination process. And here's the pathology part, showing the quetiapine is neuroprotective and also prevented mice-induced, cupzone-induced demyelination. And here's the recovery process. We induce the demyelination first, and then use the medication to treat later on. So the recovery is much accelerated with quetiapine, and follow up with the behavior parameters, coordinates. And also look into the neurocortical cell culture, and it's a small brain in the culture environment, and showing the quetiapine enhanced myelination process. So that's the work we published in the molecular psychiatry a few years ago, and we move on to use a similar model to study RTMS in animals. So the RTMS actually is quite popular right now, certainly in Canada. The UT, University of Toronto, got a major center, is leading the research, and in University of Alberta, we just start to use into human population with research. And this is RTMS treatment for depression, and this in series model, and influence the different nuclei or pathways of related to so-called hypoactive brain. And we use this animal model we mentioned before, and use those high-frequency RTMS stimulation, and also look at the social interaction. And we saw RTMS improve social interaction, and reflected by demyelination process with pathology analysis. This is the use of human-based machine to animal, but we also developed a new animal model, actually stimulation process, use those unified low-density RTMS or TMS. So it's just the magnetic field, and the animal is free-moving, no need to fix, and so in this way, we put the animal there for a little bit long time, and then stimulate by this. And then we have a remediation study, and we have RTMS plus cupidone model and see what happens. And we look at the pathology, and we look at the other marker, PDGF, and also we look at the GFAP and other markers for the neuronal and glial-related parameters. And also we look at other parameters. And in the end, we say this kind of a treatment with the new stimulation with the unified field also produce a very much benefit effect in this cupidone-induced model. The next work I would like to introduce is from one of my students, actually, Dr. Sodaderson is a co-supervisor and in the committee, and treating depression with ultrasound. So we have ECT, electricity. We have RTMS, is magnetic field, a different kind of field. And right now, say what happened with ultrasound? We know those neurostimulation therapy, I don't think ultrasound is in the popular population treatment yet. So what other choice? So there's literature reporting the transcranial ultrasound effect on mental state, and mainly working on Alzheimer part. So we look at it into this, and here's a quick fact about ultrasound. So ultrasound is the really have energy delivery, and the infrared, infrasound, ultrasound, acoustic, that's what you can hear from me today. So the ultrasound is high frequency and deliver energy. And if higher energy will reduce heat energy, and lower the energy will mimic as a micro, nano massage to the cell membrane or to the brain tissue. So the ultrasound in neuronal circuits, low intensivity ultrasound is capable non-invasively excite neurons and network. So I will say it's a massage, different way. So we will look at say depression. There's so many different kind of theories and what the ultrasound can do. So we studied the ultrasound, use the different parameters in depression, and also different models. So working hypothesis is ultrasound could be a potential treatment for depression. And neurotrophy and neurogenesis is probably the potential target for the ultrasound. So here is the ultrasound model we use. Initially, we start with the ultrasound to treat the growing neural cells, stem cells. And this collaborate with Dr. Jie Chen. He's the leading expert in the world actually for the ultrasound utilization, especially in medical field. So here is a low intensity pulsed ultrasound and can do a lot of stuff. And then we use this to treat the cell, look at the growth cell line toxicity or the energy delivery curve. And here is the experimental setup for animal study. We can see they'll put the small mice there and fix the not the electrode, the stimulation pad to the ultrasound, to the whole brain. And we do the behavior tests and related to depression and cognition. So here's the behavior test showing the ultrasound beneficial, and here's the behavior tail suspension test showing ultrasound is beneficial. Here's Y-mice test regarding the cognition memory part, and here is the pathology showing the different markers, especially BDNF in hippocampus area. So the result is low intensity ultrasound increase of viability of neuronal cells, and also improve the depression-like behavior induced by stress and reflected by BDNF parameters. And we want to look at what's the mechanism of ultrasound. So we come back to our working hypothesis. We believe the white matter does matter in depression. So we come back, use this cupidone-induced demyelination model again, and to see if ultrasound have impact on white matter integrity in addition to BDNF or neurotransmitter storage. So here is a Cupidon model again, and pathological test. We show the ultrasound increased level of myelin-based protein, MBP, in mice. And we also look at the neural and glial antigen 2. That's the pre-marker for glial cells. So we really show those animal models away from gray matters, neuronal parameters, and away from transmitter. We focus on white matter. So the potential mechanism needs somebody better than me to figure out, but we have some initial thinking about where they're working on it. So to be common language, I would just say it's like a massage and make the neuronal more active and projective. So the conclusion from this work, the white matter does matter, and white matter will be the mechanism study or drug development target, and hopefully there will be more human studies showing that. So we have collaborators in other universities. University of Saskatchewan, we have this machine used in the human population and also beyond depression using Alzheimer's, ADHD, and autism. To summarize my discussion today is oligodendrocyte degeneration probably important in depression, and there are some evidence if we look into it, and RTMS and ultrasound, and as good as medication in all those parameters, but we should thinking some parameters beyond the medication target. So right now we really use all the target and the parameters that we have been using to study the medication, and we should look into more myelination oligodendrocyte pathways beyond the neurotransmitter or neurotransmitter receptors. So the white matter does matter. So here's the model, and we hopefully some other colleague will work on it. So I acknowledge the contribution from my colleague and student. Thank you very much.
Dr. Lee, that was a great presentation. Thank you so much. Are there any questions from the audience? So I have one. Do you have a question, Andrew? Yeah.
So Shimin, thank you for a clear presentation. I had a question about the animal models in different phases of your presentation, because with the last part you had a number of animal models looking at stress and so on. Did you do that in the earlier part when you were looking at the Cupidon model and white matter changes?
Yes, so we use a different model in the lab. Stress is quite typical. And in recent years, the unpredictable chronic stress is more versatile. We use that. But in the target, that is a tradition for all the medication, all the manipulation for depression models. But right now we use the Cupidon model as a mainstay in the lab, because that one with the low dose Cupidon model only damage the white matter, induce cognitive and executive function, social interaction, without the damage of sensory or motor capacity. So we really believe that is not traditional model. Hopefully we'll target white matter more effectively.
So one question in terms of neurodevelopmental changes, I don't know if you or anyone else has done this, but looking at regular animal models as the baseline and not Cupidon, is there any evidence for white matter changes when there's an early insult, looking at that kind of animal model approach?
We spent quite a bit of time with one postdoc, but we did not get any data, and the postdoc left. We used the autism animal model with the one injection, and induced the pregnant mother's mice. But in the end, we did not go to that stage. It'll be interesting. Right now, we are doing collaboration with a colleague in South Australia, use the autism, small children, see if they're benefit. But it will be hard. Sometimes they argue the autism have hyper intensity of white matter initially, and not enough pruning process. So in this way, right now we're talking about white matter damage, and down the road probably we're talking about white matter integrity, and then we'll talking about white matter efficiency down the road. Probably too much wiring, probably better off like the Apple cell phone with wireless earphone rather than with so many wire. So it's a very interesting field. Yeah.
Shimin, I have one more question. You have mentioned HPA axis as a pathophysiological model for depression and stress per se, as depression as a consequence of stress maybe. Are you looking at any blood markers of HPA axis dysfunctionality? They might be easy to obtain.
We did not. That's a very important area. People pay a lot of attention for many years. And the problem was people try to develop some medication in that area to influence that axis, and without a major success. So the people get trendy to study the neurogenesis in many years. Right now, I think they move to neuroimaging markers and genetic. Yeah. But we keep the animals' adrenal gland in my deep freezer. Someday there's some new marker come back. We'll see what happens. Yeah.
Thank you.